Wait a minute, she not sliding. Okay, here we go. All right. So what I plan to talk about is PET-CT and radiation treatment and any recent advances that have been done. So if there's anything you don't understand, let me know. Okay, so I'm going to first kind of go through a little video of what PET-CT is, and then you guys we can move from there. Okay, so
PET-CT combines two different imaging technologies in a single scan: positron emission tomography, or PET for short, and computed tomography, or CT. Together, they result in a highly sensitive test that allows physiological changes to be precisely localized and evaluated at an early stage. PET measures the body's biological processes. CT generates high-resolution cross-sectional images of the body's anatomy. By combining both sets of information into a single, three-dimensional image, metabolic processes are mapped precisely and in all spatial dimensions. This helps to reveal the patient's condition at a very early stage. The combination of PET and CT gives a more accurate
did it go away?
than the two scans performed separately, helping to facilitate a more accurate diagnosis.
It's okay. Someone's entering the class, so I guess it keeps.
Physicians use PET-CT scans to aid in the detection of tumors and metastasis. Scans can also aid in distinguishing between malignant and benign changes at an early stage, determining the stage of a disease, developing a treatment strategy, and monitoring the response. PET-CT scans can also be used to evaluate Alzheimer's disease and heart disease. Metabolic activity is measured using so-called PET tracers. These are weakly radioactive biomolecules that behave like normal biomolecules and accumulate where needed. The PET scanner records an image of the tracer distribution as it collects in areas of higher metabolic activity, similar to cars gathering in a parking lot. These areas show up as bright spots on the PET scan. In principle, any biomolecule can be a tracer. Most often, however, radioactive labeled glucose is used, so-called 18F-FDG, which accumulates in tissues and organs with a high energy demand. Since the tracer decays quickly, it must be prepared anew before each examination. Before the PET-CT scan, the tracer is injected.
Excuse me, guys. Um, wait a minute. Excuse me, hold on. Excuse me. I have somebody at my door. Give me a minute.
Like we all get interrupted, don't we? Well, let's welcome in Dr. Evans. Good morning.
Good morning, Dr. Holloway in class. Yes. I got held hostage on the metro today.
Sounds like everybody has some
Yeah.
transportation issues or traveling issues. Yeah.
Mm-hmm.
Parking issues or what have you. Okay.
Yeah. It was rough, but we're here. Which is
Yes.
great. Yeah. So, and it's St. Patrick's Day. Happy St. Patty's Day, guys.
Oh,
I
that's
apologize, guys. Like, students first. I apologize for that. All right. So, where were we?
back at the video. Can you replay it?
Yes, of course. I'm
Thanks.
trying to see why she not liking me. Okay, wait a minute. Where am I? Okay, and we're in the opposite direction, aren't we? Okay, we're here.
Okay. You know what?
Thank you.
It hit
What do I need to hit, Doc?
I was gonna say we could do it on never mind, just leave it there. It's okay.
Can you guys hear it good, or are you guys hearing it through my speakers?
I hear it okay. I don't know about the
Guys,
guys.
let me know. Is everybody hearing it good?
Yes, we can hear it.
Beautiful. Thank you.
All right. If you could just start it from the beginning, that'd be
PET-CT
great.
combines two different image.
You got it.
Oh, Lord. Don't judge me. I'm old.
PET-CT combines two different imaging technologies in a single scan: positron emission tomography, or PET for short, and computed tomography, or CT. Together, they result in a highly sensitive test that allows physiological changes to be precisely localized and evaluated at an early stage. PET measures the body's biological processes. CT generates high-resolution cross-sectional images of the body's anatomy. By combining both sets of information into a single, three-dimensional image, metabolic processes are mapped precisely and in all spatial dimensions. This helps to reveal the patient's condition at a very early stage. The combination of PET and CT gives a more accurate picture than the two scans performed separately, helping to facilitate a more accurate diagnosis. Physicians use PET-CT scans to aid in the detection of tumors and metastasis. Scans can also aid in distinguishing between malignant and benign changes at an early stage, determining the stage of a disease, developing a treatment strategy, and monitoring the response. PET-CT scans can also be used to evaluate Alzheimer's disease and heart disease. Metabolic activity is measured using so-called PET tracers. These are weakly radioactive biomolecules that behave like normal biomolecules and accumulate where needed. The PET scanner records an image of the tracer distribution as it collects in areas of higher metabolic activity, similar to cars gathering in a parking lot. These areas show up as bright spots on the PET scan. In principle, any biomolecule can be a tracer. Most often, however, radioactive labeled glucose is used, so-called 18F-FDG, which accumulates in tissues and organs with a high energy demand. Since the tracer decays quickly, it must be prepared anew before each examination. Before the PET-CT scan, the tracer is injected into a vein in the patient's arm. After that, the patient must rest for an hour to allow the substance to spread through their body. Then the examination takes place. CT uses X-rays and images multiple layers of the body in succession. The PET scan registers the decay of the tracer by means of the gamma rays emitted. A fused image is created from the dataset. (18F-FDG) glucose has a short half-life. After 2 hours, only half of the radioactivity remains. After 4 hours, only a quarter, and so on. The radiation dose from the two examinations corresponds, on average, to the annual natural background radiation to which every individual is exposed. At present, PET-CT scans are used to make mainly static images of the metabolic processes. The future will be dynamic imaging that captures and quantifies the metabolic processes over time. This will give physicians additional information to be able to diagnose, stage, treat, and monitor disease more effectively.
All right. So this is basically what is PET, right? It gave you a precise definition of what PET is, but now why would you want to know? Why? Why do you care? Because PET-CT is the standard for staging and restaging of tumors. And for the purposes of what you guys do, it is what is used for radiation therapy planning. And it's basically iterative in terms of it repeats itself, right? So what is the significance? PET imaging allows for tumoral features to be quantified. Basically, how are we going to treat this tumor? What are the doses we're going to use? what are the boundaries we're going to have. So all of this information is gathered by us, given over to your planning team, and then that basically informs how you guys are going to move forward, right? So some of the advantages of PET include that it provides some precise information about the metabolic activity, which was already, stated in the video. It allows for delineation of target volumes for radiation therapy, and it is the gold standard for staging. And it also has historically even changed the category of tumors on the TMN, okay, or TNM, okay. So please stop me at any time if I'm going too fast or if there are any questions. Okay. The structural and functional image. So what does PET provide? So PET improves staging as well. It allows for personalized treatment because it allows us to know what is the metabolism of the tumor. It allows us to see and target the tumor differently, and it allows us to see location, how to address the the tumor in terms of respiration, and just monitoring how the tumor is responding to treatment as well. So, like I said, it is the gold standard. It is used for planning. It is used during, and it's used for reassessment as well. So, all the target volumes are basically gained through the PET image, right? So let me see here. All right. So what are some of the radiopharmaceuticals? So he spoke about F18. So F18 is analogous to glucose. So can anybody tell me what glucose is analogous to? What is glucose basically? Anybody?
Sugar.
Yes. So what we've learned over the years is that tumors have their own metabolism. So when I think of that, I think of a child eating a cookie becoming hyper. So tumors have their own metabolism, and so it will take up or avid. It has an avidity or to the glucose, right? So that is the main. So FDG is the most used radiopharmaceutical. However, as time has gone on, we have used other radiopharmaceuticals. So the carbon-11, these are more for brain and neuro-oncology, right? The carbon-11, the fluorine-18 meth, all of these have been used for brain tumors, right? Because before F18 was the standard and we would only use F18, but we've diversified most recently, and we are now making radiopharmaceuticals that go to specific tumors. So this also informs the way you guys take in the information, because different radiopharmaceuticals uptake in different manners. So these are amino acids, and they leverage the fact that tumors exhibit increased protein synthesis, right? Whereas F18 leverages the tumor's metabolism being different from the patient's metabolism. So it basically tricks the body, right? So that's what we do. And we trick these disease processes into taking up this radiopharmaceutical, all right? So what is the protocol? So there is a standard protocol, right? So the standard protocol is historically FDG F18, and it has a huge patient prep. So historically, your patient is fasting. Your patient has to be fasting 4 hours or more. You want to know a good patient history, because diabetes, if your patient is diabetic, pre-diabetic, that is of consequence. Anybody want to guess why? Why is diabetes or a history of diabetes of consequence with particularly FDG? Anybody want to tell me?
Does it spike your sugar level more?
I missed half of what you said. I would love to hear it again, though.
Does it spike your sugar level more?
Correct. So if so, one of the patient preps as well is we have to take and we have to assess the patient's glucose levels. So you do that with a glucometer finger stick, So you have to inform if your patient has a glucose level of 200 and above or 200 and below. So 200 and above is a no-no. It forces you to have to reschedule your patient. But anything below 200, you're able to move forward. Additionally, this informs how you schedule your patient, right? If your patient is diabetic, if your patient is type 1 or type 2, do they eat? Do they not eat? And come later on in the day, because pets are done all day, right? So some of your patients may have to come with fast acting insulin, and some of your patients may have to come first thing in the morning. And then other patients, type 2, who are taking the oral, may have to, come later on in the day, right? So they talked about the FDG injection. They showed you that. The FDG injection is given IV, right? You have to give a saline push. You do have to have venous access. And historically, you wait up to 60 minutes for uptake time. Now, during uptake, your patient is not allowed to do anything strenuous. Not the day before and not during. So the day before, no leg day, no workouts, no nothing. Neither are they able to text or do anything strenuous after. Why? Why do you think that is? Anybody want to guess why that is? We have any workout people in here? Anybody working out every day? I can't see. I can't see them, Doc. So, okay. Glucose informs goes to your muscles. So if you're working out, your muscles are going to take up the glucose. So if you have workouts, if your patient had a strenuous day, if your patient is texting, those thumbs are going to be hot. We've seen where if your patient is typing, those hands are going to be what we consider hot. Hot means that the activity is going to go to those areas because glucose is naturally occurring in the body. So the patient basically has to be injected, take a nap, be in the recumbent position or the seated position for 60 minutes, and then go to the imaging table. So the dose that is given is historically between 7 and 10 millicuries. And sometimes it can be contingent on if the patient is heavier, because if the patient is heavier, you want to go towards the higher level of the range, right? Your patient positioning is usually supine. And depending on the type of cancer, you want the hands up above the head or to the side. So if you're doing head and neck cancers, you would want the hands up above the head. To the side, and you want that head area and that neck area clear. If you're doing whole body, you would want the hands above the head, and then you would do the rest of the body, right? So historically, we do skull base to mid-thigh, which is basically eye to thigh. And that's historically what an FDG standard protocol is like, right? So that takes approximately 1 to 2 hours from injection to follow through, right? To everything being done. And then the other protocol is the gated PET CT. So the gated PET CT allows for the respiration to be gated and for us to see how the tumor moves during respiration, and how that will inform the way that you guys are basically giving your therapy while the patient breathes, right? So does the tumor move? Is it gonna move? And so what you do is when you gate the PET CT, the images are taken with the respiratory cycle, right? And that, like I said, that informs everything about how your planning is taking place, right? So here are some other radiopharmaceutical tracers that we're using. So F18, we use it with FDG, but we also we have tagged it to other imaging agents, and you use it for different prognostic things, including, like I said, target delineation, prognostication, and any progression, right? So these are just some examples of some of the other radiopharmaceuticals that we're using. Some of these are fairly new to the market and are recently, here you can see the ligands are still in investigational, but DOTA-TATE, DOTA-TAT are fairly new. The FFET is fairly new as well. And then FDG has been our gold standard for some time now. Okay. So the radiation therapy planning. So here is your cycle. You have the imaging, CT, MR, PET, PET-CT, or PET-MR. PET-MR is actually new. And with that, you get your stage, right? Your staging tells you basically your T, and M, and basically how are we going to approach this. So what are your target volumes? Anybody know about these volumes, your gross tumor volumes, your clinical target volumes? Because I know you guys are in clinicals, correct?
Yeah,
Yes.
How do these inform your experience at clinicals? How do these values, how are they like, what do you guys do with them? What does gross tumor volume represent? Anybody?
I'm sorry. So we have actually haven't studied those, but I think I have an idea of it. That's
Mm,
like the total of
okay.
every, but we've not studied it.
Okay, so you guys haven't officially studied it. Is there something okay, so I just wanted to know that, so even when you're at clinicals, it's not something that you see them apply in real time.
it's
We see
usually
them in real time. Like we see
Okay,
them.
the young lady had to,
Oh, sorry.
you don't see it in real time.
We see it in treatment planning, like on the CT image, it says like the PTV is outlined on the image, so then we can see
Right.
it.
yeah, it's
Okay.
usually on the DRR too. It's like kind of showing like the extent of the tumor and how much like
Mhm.
they're treating, if there's lymph nodes and all that good stuff.
Oh, see, I like this. Okay, good. So thank you for sharing. So these all inform how you guys are expected to treat the tumors, right? So the gross tumor volume represents the visible or palpable extent of the primary tumor as seen in imaging scans, right? So that's the gross tumor volume, right? So this is how these sorts of imaging inform how you guys move forward, right? The clinical target volume encompasses that, but also includes the microscopic or unimaginable, excuse my language, tumor spread. So that it deals with you in terms of what's there. Is it lymph nodes? What all is involved in this particular tumor, right? So like I said, this all informs how you guys, your plan moving forward. They plan it, but you guys execute. So this gives you the plan to execute. Yes? And the planning target volume is created by adding a margin around the CTV to account for variation in size, shape, and position of the tumor relative to the radiation beam. Okay, so it ensures that the CTV receives the prescribed dose. Okay, so this has to all do especially where you go, right? And then this is basically your cycle, your treatment planning, your simulation, and how the things that you're going to do, and it's going to become basically your life's work as you move forward as a radiation therapist, right? All right. So prognostication. What does PET-CT do for prognostication? PET-CT allows outcomes to be predicted and for the treatment to be tailored to the patient's specific conditions, right? Like I said, so like, is it benign? Is it malignant? You know, what all does it involve? And that all comes from PET-CT and other imaging modalities, but mostly PET-CT. All right. So what is the role of PET-CT in therapy planning for specific tumor types? So for the non-small cell carcinoma, it impacts target volume delineation and it improves the accuracy of staging and treatment planning. And for other cancer, it defines your treatment volumes and it improves the outcomes. So what you're going to see is a lot of times based on the assessment and reassessment, it can be predictive of if your therapy is going to be failed or not. Do you need to elevate the dose? do we need to see what else is included and how we color or paint the margins of the tumoral lesion, right? All right. So some of the clinical applications across the board are for these different forms of tumors. So you have the neuro-oncologic tumors for assessing metabolic activity, the head and neck tumors, to see if it's lymph node involvement and the extent of the primary tumor, because a lot of times you go in or there isn't a known primary tumor, but PET-CT allows that to be delineated better. For lung cancer, it is absolutely crucial for staging, defining the target volumes, and in some cases, it even refines the TNM, okay? For gastrointestinal tumors, it allows for identification of metastatic disease and tumor delineation, and then for prostate cancers, it deals with assessing the extent of the disease. All right. So what are we looking at here? Did we do cross-sectional anatomy yet?
Yeah.
Anybody? Oh, we did do cross-sectional anatomy. What am I looking at? Anybody want to tell me what I'm looking at? I mean, it kind of tells you, but what am I looking at, guys?
The lungs.
And axial image. I think I see the heart. The
Okay.
thorax.
The thorax. Okay. She says she thinks she sees the heart. Do we see this? This is the lungs. Do we see this? Do we see how it glows? What does this glow tell you?
That looks like, I think it's tumor, right?
Right. So it's glowing. We call it hot, but it's glowing because, so remember you have the CT that you superimpose, or you take the two images together, right? So this is PET with F18 FDG, for non-small cell lung cancer has become the gold standard for staging this. Okay. Usually the PET was used to complete the staging and prevent unnecessary surgery. So at one point, surgery was the only way, but right now, that is not the case, right? So the combined information from this hybrid has become more useful than to do them separately, right? And so in regards to the treatment planning, the the F18 FDG PET has proven to have a more accurate target volume delineation, thereby allowing PET-CT to be the standard method for acquiring baseline staging for radiation therapy treatment for this particular cancer. So you have to go through a PET-CT image if they're treating this. It had become the standard, right? And I mean, standards change. We now have a PET-MR, but that hasn't become the standard just yet. Okay. Prostate cancer. Right? So this is squamous cell carcinoma of the anus. It is a rare malignancy, right? It only accounts for about 1 to 2% of gastrointestinal tumors. So radiation therapy is the preferred modality for addressing this type of cancer. And the reason is because of where it's located, right? And so for the purposes of this cancer, surgery is historically only used as an intervention for salvaging purposes, right? So this type of tumor exhibits a significant avidity to F18 FDG, right? And the PET-CT has become invaluable in staging here for prostate cancer. It's the way that they're actually staging all of them. When it comes to radiation therapy planning, the metabolic information is instrumental for delineating the target areas, and it enhances the primary tumor. So sometimes they don't know where the primary tumor is, but this allows them to locate it. FDG F18 facilitates the identification of any involved lymph nodes and ensures those inclusions in the radiation field. So they make sure that they use this because they want to make sure that they have a comprehensive view of what is actually happening in the prostate. Okay. Head and neck cancers. What are we looking at here? Anybody want to tell me what we're looking at?
Someone's tonsil.
Good job. She's like someone's tonsil. Good job. Thank you. So head and neck cancers. Those are, can be particularly aggressive. And so the head and neck cancers can be in the salivary gland, nasopharynx carcinomas. They can be pretty aggressive. And so this is the PET-CT, and this is the planning to show that they, everything they plan to do here, right in this corner here, right? So here, PET-CT details the tumor biology and tissue metabolism around it, and usually is pretty accurate in detecting if there's a nodal metastasis and if there's tumor extensions. So it allows that to be included in the field for what you guys are going to be doing, right? Let me see. Any questions here?
So was this specific cancer a precursor from HPV infection?
This HPV positive. So, they say HPV can bring on, like it is one of the reasons that they started the HPV vaccine. So it's a form of human papilloma virus.
Thank you.
Not, okay. So response assessment. So, and I said this before, during and after therapy, PET-CT is used to gauge the tumor's response to what you guys do, to the therapy that you guys are going to be administering, right? And it allows the monitoring of changes to the tumor to be tracked and documented, right? PET-CT also allows for clinicians to predict patterns of failure and identify if there's a possibility of recurrence. Do we need to up the dose? How do we try to make this? So it's like assessing in real time. So this is how come for us as nuclear medicine technologists, we might see a patient every 3 months, and then that's shared onto your team for planning purposes, right? To get to see how the tumors are reacting to the radiation therapy. And the oncologist gets to work with you guys and your team to move forward on that level, right? So in conclusion, the integration of PET imaging has improved the accuracy of radiation therapy planning, the treatment response, and the assessment and prognostication. And then it provides very detailed information to allow a personalized and effective treatment strategy, right? So these are my